Welcome to the Heart of Prevention, helping clinicians stay up to date on preventive cardiology. This show features leading experts discussing real-world strategies to prevent heart disease, from lifestyle changes like diet and exercise to medical treatments, including new therapies. Whether you're a medical student, resident, or practicing clinician, this podcast challenges, informs, and enhances your approach to cardiovascular disease prevention. The Heart of Prevention, keeping hearts healthy one episode at a time. I'm Dr. Michael Shapiro, President of the American Society for Preventive Cardiology, and now here's your host, Dr. Keerthana Pakanati.
Dr. Petek, Dr. Moulson, welcome to the Heart of Prevention.
It's great to be here. Thank you for having us.
So I'm really excited about today's episode, especially with the time of the year that we're in. But we're going to be talking a little bit about sports cardiology, and I'm excited to learn about a topic that's relatively new to me and probably a lot of the people that are listening to today's episode. Well, let me tell you a little bit about both of y'all for the people that are listening. Dr. Brad Petek is the Director of Sports Cardiology at Oregon Health and Science University, and Dr. Nate Moulson is the Clinical Assistant Professor in the Department of Medicine and Medical Director of Vascular Health and Prevention at Vancouver General Hospital and the Delory Cardiovascular Institute. So I always like to ask the guests when we start off, how did you get here? How did you figure out what you wanted to do, especially since you guys are shaping not only in the prevention field, but also in the field of sports cardiology? It's all really new. We'll start with you, Dr. Petek.
Yeah, thanks so much again for having us. And, I think like most people that get interested in any field of sports, I grew up a sports fan growing up and have loved sports kind of my whole entire life. And then when I got to medical training, I ended up seeing a lot of athletes being restricted due to heart conditions. And there's not a lot of guidance to guide, hey, what is safe during exercise and what is not safe during exercise. And as I became more and more involved, I realized that what I love the most about this job is really working with athletes on a one-to-one basis to understand the benefits and also the risks of exercise, to help them make the most informed decision on whether they want to play sports or not. For a lot of young people, like an 18-year-old college athlete, sports are their entire identity, and it's all that they have thought about their entire life. And so really getting on the level of the athlete to say, hey, what's important to you? And what are the potential risks of the heart disease? And what can we do to make the best decision for you as an individual, rather than just these blanket decisions? Hey, you can play, you can not play. And that has kind of been the most fulfilling part of this job.
I love that even at the beginning, the focus is always on the patient, right? That conversation about one-on-one and really individualizing everything for these athletes, for sure. Dr. Moulson, what about you?
Yeah, so I think I have a somewhat of a similar journey. I was actually a clinical exercise physiologist before I went into medicine, and I share Brad's story there that I was somewhat of a failed athlete myself, always been involved in sports and exercise. And I think if you ask a lot of those in sports cardiology, there usually is a similar story where we enjoy that so much, really want to do what we can to be able to continue to be involved. And I think pairing that with cardiology, it was just a natural fit for me. So I think I was going through training, the ability to see that patients that had athletic goals that wanted to pursue these endeavors that most of the time maybe wasn't the primary focus of the appointment, but from the patient side of things, they were always bringing up, well, I want to get back. I want to do this. I want to do that. Does my heart condition limit me? I saw that there was a real need and to be able to address that and to be able to individualize the approach for the patient so we can help them and support them getting back to doing that. I think we'll probably touch on this later in the podcast as well, but there's been a real paradigm shift in sports cardiology, really from looking at, we're not doctors that make eligibility. We're not trying to restrict patients. We're really trying to help them understand what the potential limitations are, what the risks are, and go through a shared decision-making process. So that's really the aspect that I really enjoy most about my job, and really continue to kind of bring that to.
I love that you mentioned you're not trying to restrict athletes, but you're creating a plan to really get them back on the field or get them back on the court and do what they love. And I'm sure that approach really allows the patients to connect with you guys at a much deeper level instead of being like, hey, I'm not here to tell you can't play anymore, but what can we do to get you back on the field? And kind of, we've talked a little bit about, the patient approach, but taking it a step back to physiology and pathology, we talk about these gray zone cases, right, where physiological adaptation overlaps with early pathology. How do you approach that diagnostic uncertainty in practice? And, along that lines, the one that I always think of in training is like athletic remodeling versus cardiomyopathies on imaging or EKGs. And we can start with you, Dr. Moulson.
Yeah, no, it's an absolutely great question. I'm sure Brad would definitely agree. It's a very common referral to the sports cardiology clinic. I think maybe just to start for our listeners who may be less initiated with the field, I think starting with a little bit of what considered physiologic cardiac adaptation to exercise, which is really otherwise known as exercise-induced cardiac remodeling, or what we know as the athlete's heart. And so this process is stimulated by like a very complex hemodynamic and neurohormonal conditions that exist during exercise and is related to both the type, intensity, and duration of exercise exposure. And while considerable overlap exists, we can think about cardiac adaptation to exercise kind of with two primary exercise categories. So isotonic or endurance exercise, which involves sustained elevations in cardiac output reduced peripheral vascular resistance, things like distance running or cycling, for example, and isometric or strength exercise characterized by kind of marked and pulsatile increases in peripheral vascular resistance, which typically with only slightly elevated cardiac output. So think weightlifting or American style football. Now there's significant individual variation, and this dichotomization is probably really simplistic because many sports have components of kind of both the endurance and the strength to them, both in training and competition. However, there's really, as you alluded to, there's the kind of overlapping with the areas of cardiac pathology. And so when we think about what potential areas where there's overlap between expected physiologic adaptations and pathology, we think about when we get into left ventricular kind of slightly increased wall thickness, chamber dilatation in the right ventricle or the left ventricle, as well as some areas of hypertrabeculation, all of which could potentially be the first sign of early pathology. So I think one of the challenges of sports cardiology is these gray zones and differentiating whether or not this is truly just an athletic adaptation or exercise-induced cardiac remodeling versus a pathologic or the starts of a pathologic process. So approaching this scenario in clinical practice really requires an understanding of exercise physiology and the integration of not only the imaging data, but personal and family history, 12-lead ECG, and you're really using exercise testing data and as a major component of this as well, including exercise imaging. But I think you alluded to it. There's clinical uncertainty here. And in many cases, it may not be all readily apparent after only one encounter. So I think sometimes you have to be able to sit with that uncertainty and be able to follow this longitudinally and not overreact to certain findings and say this could be something, it may not, and really being able to have those discussions and convey that uncertainty to patients is a skill and an area in sports cardiology that really requires mastery. I think we're all still work on it as well, but one that we have to kind of face in clinical practice. I think there's just some areas that I think if people listening to, okay, well, we could go through each of those scenarios I talked about there in detail, but that would take an entire podcast in and of itself. So some clinical pearls I like to, when teaching trainees or talking to those maybe less initiated in the field, really to make sure that you take a detailed sports and exercise history, because understanding what that patient, that athlete is doing will really help you match the expected cardiac adaptations to what you're seeing on the testing. So, if you're seeing someone who's a weightlifter and they have a lot of chamber dilatation, that may not match with that and maybe raise the flag to think, okay, is something else going on here and vice versa. And the other one is symmetry is key in these cases. And so a lot of the time when we're looking at patients, when they do, performing high volume endurance exercise, we really want to see at least relative symmetry to the chamber dilatation. And when we see significant asymmetry, we typically think, okay, maybe something else might be going on. Not always, but it does raise that flag that we should be thinking there may be some early pathology there. And lastly, I would really put a plug in for doing maximal effort exercise testing, including cardiopulmonary testing in these patients and exercise imaging where appropriate, because it can be really helpful in kind of differentiating these gray zone cases.
That was so awesome. That was like a perfect introduction to all of the physiology. I feel like I learned a lot. I needed to have taken notes. I'm glad this is being recorded. But I love the point that you made about everything starts with the history, right? And like we have to understand what kind of activity they're doing. Like sports cardiology is a very general term, but there's so many nuances depending on what sport they're actually doing, which I must admit I didn't even think about until you actually explained it that way. Dr. Petek, what about you?
Yeah, I think Dr. Moulson is much more eloquent than I am, but I think he hit the nail on the head there. I think the biggest thing is, who's your athlete? Is this somebody who is exercising 15 hours a week where we expect them to have lots of remodeling of their heart? Or is this a beer league hockey player that's playing once every 2 weeks and kind of coming off the couch on their weekend or two, would not expect the changes? And I always tell people, it's really important. We do have some clinical practice guidelines out there that not actually a lot of even cardiologists, I think, know of. So we have ECG guidelines called the International Criteria, which were published in 2017, that are really helpful to say, hey, what is normal for an athlete and what is not normal? Because a lot of the times people come into the ED and they're like, oh, wow, this looks like somebody's having a heart attack when it's just a totally normal athlete sitting there. And so we have clinical practice guidelines. The ECG ones are called the International Criteria. And then there was an imaging guideline that came out in 2020 in the Journal of the American Society of Cardiography. And there's actually a new paper that just came out of JACC Imaging, looking at imaging in masters athletes. And so I really implore everyone as they're trying to get into the field to look at these documents and to help them as they get through the way, and then phone a friendly sports cardiologist. So I think the fun thing about this field is it's rapidly expanding. And so now there's lots of people getting involved. And this is what we do all day, every day. Dr. Moulson and I just we nerd out all day about looking at athlete ECGs and echoes. So I think understanding these gray zone cases can be very difficult, but, we're always here to help. And I think it can be really helpful to get a sports cardiology colleague involved.
I know who to call since I'm in Seattle and I'm on the West Coast too. I will say we did use your guidelines. We work with a nonprofit here in our fellowship where we actually screen young athletes, like I think age 12 all the way up to 18. They get a free EKG screening and then they get CPR trained and then they get a free echo if there's any abnormalities. And it's a really cool nonprofit here started by someone who was affected by sudden cardiac death in their family. And so yeah, I have a little bit of experience in that, but I really enjoyed getting to talk to all the athletes in all the different sports. But I'm going to keep that in mind to get that thorough history and find out what exactly I should be looking for. So we talked a little bit about, the athletic context, but a lot of athletes think, exercise equals immunity from disease, right? And so how do you frame prevention to someone who's otherwise athletic and they're exercising and doing what they're supposed to be doing? How do you really frame where prevention fits in there? And there's probably not an easy answer for this. This could probably be a whole episode too, but we'll start with Dr. Petek.
Yeah. So, I actually think this is probably one of the most important aspects of sports cardiology. And the reason why is that lots of people who've exercised their entire life says, Doc, there's no way I have heart disease. I exercise, I do everything right. There's no possible way when I exercise 15 hours a week that I have coronary artery disease or I have this. And so I think the biggest thing to stress to athletes is that exercise, while wonderful, does not make you immune to cardiovascular disease. So obviously, we all know that there can be genetic factors. And as my mentor had said, he called it the porta potty talk. But lots of people when they're at these races will talk about, all the supplements they're doing, all of the, their diet where they're eating lots of high meats and high, fat diets. And there's all these other lifestyle factors that a lot of athletes don't have at the top of their mind because they think that they can be immune to disease. And so, I start by first getting on their level and just say, hey, the biggest thing is that exercise doesn't make you immune to cardiovascular disease, but we need to figure out kind of what's best for you and what could be related to exercise and what's not, and try to get on an athlete's individual level. And then I think it's a huge, huge importance to be able to take a really thorough supplement and performance enhancing supplements history. Our field is a little bit different than a lot of others where lots of people take a whole bunch of supplements that are not FDA regulated. And so, when I'm seeing an athlete in clinic, I say, hey, what is every over-the-counter medication or supplement you're taking? What are all the performance enhancing supplements that you're taking? I list them all out individually because that affects their cardiovascular risk and overall health. And so just knowing everything that an athlete's putting in their body.
Yeah, that's a great point about the supplements too, and making sure that you kind of individualize, there could be multiple that they're taking and have them discuss that with you. Dr. Moulson?
Yeah, I think I would really echo that. I think one of the phrases that I use a lot in clinic is you can't outrun your risk factors. I think a lot of patients feel that way, that they can exercise away their dyslipidemia, their hypertension, their family history. And a lot of what we do is educating that, yes, well, that's absolutely, high cardiorespiratory fitness, high volume exercise undoubtedly reduces long-term cardiovascular risk and overall health risk as well. it doesn't negate the fact that you still need to potentially be started on treatment for those and need guideline-based indications for that. From a practical standpoint, I'd say I'm sure Brad would agree with this as well. There's a lot more hesitancy, and we spend a lot of time discussing, particularly when it comes into lipid lowering therapies. There's a lot of information out there that, a lot of these patients are very engaged in their health. And so they're going to come to you with a lot of questions around, well, I read this, what about this potential side effect? What about this study? And so being aware of that and knowing that, some things that there's never a simple intervention appointment, but, sometimes we look at, we're going to talk about just lipid lowering therapy today. That can be a long conversation with a lot of these masters athletes, which is an area we quite enjoy and where that overlap with prevention exists. I will say we have, that's one of the areas that we really could do better in sports cardiology when we're talking about how we link that with prevention, is better understanding how risk scores and traditional risk factors integrate with exercise and high volume exercise to be able to help more individualized patient risk, because that's really what patients are asking for when they come to us, is how does this factor into my overall cardiovascular risk? And we know it does. We just don't have the precise data to be able to give them kind of more the answers they're looking for. And sometimes that can be, but even just having that conversation with patients can really be helpful for allowing them to be optimized to be able to understand their treatment decisions.
Yeah, I can imagine that the lipid lowering conversation would be the entire appointment. But I think that's a great point you made about the fact that we don't have a lot of data for how a really athletic person kind of factors into their risk factors and their risk score. And so trying to find a way, again, the focus is all just individualizing risk and individualizing the conversation, but we have to know how that factors into an otherwise, like, okay, your general risk factors and the ones that we know, affect your heart, but you're active, and how does that balance out? And so probably more to come, I'm guessing, from the field of sports cardiology for how to integrate that into our traditional risk scores that we do have. I kind of wanted to turn to the talk about wearables and technology, and we've, with more people having monitors, whatever wearable they're using. How has that really changed the detection and management of arrhythmias? And are you seeing athletes coming in that are like, hey, my X device told me this is going on. How is this going to affect me in play and things like that? We can start with you, Dr. Moulson.
Yeah, I guess my first comment on the subject of wearables, that if you aren't ready to be inundated with patient Strava and wearable data as part of the clinic here, sports cardiology may not be the area for you. But joking aside, I think there's a lot of potential benefit there. I don't think we fully realized it with wearable technology. I will say, we get direct referrals. I'm sure many do in the field, not just in sports cardiology, but outside, for those of our consumer device detected arrhythmias in particular, or abnormalities on there. And so having a good understanding of the limitations of that data is important in this space, just to not necessarily overcall things. Patients love to hone in on, I was doing the X workout and doing these 30 seconds, my heart rate was higher than expected. So what does this mean? Do I have an arrhythmia? But on the flip side, I think there has been some, excellent progress in that space. And I have many cases where patients have come to me, either they've experienced symptoms that have been diagnosed, and they were able to pick this up with the use of a wearable device. And sometimes it can be management altering decisions, like a new diagnosis of atrial fibrillation, which massive athletes do have some degree of increased risk for developing. So I would say there's still some limitations in terms of whether or not these, monitoring things like arrhythmia burden, picking up other arrhythmias outside of atrial fibrillation. But we are starting to see a lot of this being integrated into clinical practice. And the flip side of it is, this is what patients want. At the end of the day, they're going to continue to drive that. They're going to continue to bring this data. They're going to have, patient-generated health data will continue to be an expanding field. And it's something that hopefully we can find a way to optimize to improve patient care and utilize it in an appropriate manner.
Yeah, I will say when I was thinking about wearables initially, I was like thinking about AFib, but then you mentioned that a patient may hone in on the fact that their heart rate goes up by a certain amount when they're working out a little bit more than other times. And I think that's just a difference in the patients that are coming to see, sports cardiologists. They're really attuned to what's going on with their body and really paying attention to those numbers, and probably bringing in lists to you guys of all of their heart rates. And so that's a good point as well. Dr. Petek.
Yeah, I would echo that. A not uncommon day in my clinic is people having multiple wearables on each arm, and coming in at the same time. why is this one saying this versus this one not saying that? And a lot of masters athletes track everything in their body. And so I think that the biggest things here are that, athletes are so attuned to their body that small little differences they will be able to catch. And so I think the biggest thing is being able to educate yourself and what the wearable data is giving you, what is data that is clinically actionable, what is not, and how to spot artifacts, because this happens all the time. I joke, but I love my engineers, but they will bring in, every 5 minutes for the last 20 years of their whole so it's a lot of data to go through, but it's actually can be really helpful, because I've had some cases where they're like, hey, Brad, every time I exercise, I used to go up to a heart rate of 160 and now I'm going up to 230s for a little bit. And we've diagnosed people with atrial fibrillation. We've diagnosed people with supraventricular tachycardias. And so I think in 2025, we all need to get into the wearables game. And I think that it's really important in the field of sports cardiology, because it happens all the time, and people are tracking more and more with their body and all of the scores. And now there is actually monitors that do continuous ECG monitoring too, that you can buy over the counter, and that are not FDA approved yet. But I have athletes that are bringing in their ECGs too, from when they're playing. And so, it's part of the game, and it's a fun part of the game, and we got to adapt with medicine. So I think that everyone needs to kind of move that way.
I think your comment about adapting to kind of what's going on is so true. Like meeting the patient where they're at and really taking the time to understand what all these devices are, so that you're not surprised when they come in with something. The live ECG monitoring, I have never had a patient do that, but I can imagine that they would have strips and strips and strips and strips to go through. But yeah, that's the name of the game, I think, in sports cardiology, as I'm learning. So I wanted to talk a little bit about myocarditis and return to play. And I wanted to know, like, since the early COVID era, when we were really figuring out, okay, if you're having COVID related myocarditis or just general myocarditis, when can you return to play? How have the recommendations really changed? And are we still kind of taking a more individualized approach, which is where I'm guessing that everything is always individualized, but what are some recommendations or guidelines for clinicians when we're kind of talking about this particular topic? And we'll start with you, Dr. Petek.
Yeah, so I think for better or for worse, COVID really put sports cardiology on the map, because everyone was concerned that people could have inflammation of the heart and get myocarditis. And so we started doing all of this testing on athletes. And for better or for worse, we realized that a lot of people don't know how to interpret testing in athletes. So all these cardiac MRIs, all these echocardiograms. But there were some good things that came out of it. So the first thing was being that we found that there was not an increased risk of myocarditis following COVID, and it's probably there's a similar risk to any viral infections of developing myocarditis. Really, it's athletes with cardiopulmonary symptoms after a viral infection were the most concerning for having myocarditis. And then this is probably one of the most important things, is we did not have a lot of data in actual humans and in athletes to say what is the risk of going back to exercise and what's the time frame. And so our guidelines used to support no exercise for around a 6-month period, about a 3 to 6 month period, because if somebody has active inflammation in myocarditis, you're at a high risk of sudden cardiac arrest and death. And then some of the studies that came out of COVID, coming from the Big Ten registry, had suggested that the inflammation may actually resolve much sooner. So it may resolve in even a month's time. And so now our sports guidelines have dramatically shifted and actually reduced the time frame that we restrict athletes from sports. And the biggest thing is, once you get all the baseline testing, prove that they do have myocarditis, make sure you ask a friend or colleague who knows how to read MRIs and you trust them. They have a clinical syndrome of myocarditis. And then retesting. So has the inflammation improved from cardiac biomarkers, from the cardiac MRI, doing a maximal exercise stress test to make sure they have no arrhythmias. And so now we've actually supported people getting back into exercise much sooner than we did before in an area that we really had no data in.
I'm sure all of the athletes greatly appreciate that as well. Dr. Moulson?
Yeah, I would say I don't have much specifically to add. I think Brad did a great job of covering the kind of myocarditis picture there. I would say it really just highlights, though, a lot of the areas of ongoing uncertainty within sports cardiology, and how a lot of the guidelines have been predominantly expert opinion based. And so that as we accumulate more data, we are able to look at, okay, can we update these guidelines, but also taking the current recommendations, understanding the evidence behind them is one of the areas of sports cardiology that's important to be able to individualize it. And when it is on a predominantly expert opinion, understanding why those recommendations exist and how we can apply this in clinical practice. And maybe I'll put in a plug there for kind of our ongoing work that Brad and I have been involved in during the COVID-19 pandemic around that area, as well as kind of moving forward is a project called the Orca study, which really looks at the outcomes for young competitive athletes with cardiovascular conditions. And it's an ongoing registry study now enrolling for a couple of years. So is anyone on the call that does see these young competitive athletes with cardiovascular conditions or borderline abnormalities that might be associated with increased cardiovascular risk, do think of potentially involving them in the Orca study, and you can look that up online, orcastudy.org. Patients can actually self-refer. And so I think that can help us in this area of understanding myocarditis, but also a lot of other cardiovascular conditions where we have a paucity of data at this point in time.
Yeah, I think the point that you made about all of this is ongoing and changing so quickly, I think is really exciting. Like, it's not every day that you get to sit down with the people who write the guidelines and the people who are doing the studies. And I think that's such a testament to we're learning so much quickly. And it's really important to be up to date on kind of the new recommendations as we're finding out more, because things do change rather quickly, especially in a field where we're collecting more information and more data. And we'll be sure to include that link as well. And I'm going to check it out also. So, I wanted to talk briefly about female athletes and what are some unique cardiovascular considerations in female athletes that, as we know, kind of our knowledge about female cardiovascular health in general, we're kind of catching up and we're starting to appreciate these changes. What are some things that you uniquely consider in female athletes? And we can start with Dr. Petek.
Yeah, thanks. So this is obviously a super, super important topic. And unfortunately, kind of like the rest of cardiovascular medicine, female athletes have been restricted from a lot of studies and previous studies in sports cardiology and sports medicine research in general. And so, I think from the available data that we have, you always have to look closely. And there's a little bit of an asterisk because most of the data is from male athletes. Um, and so what have we found? So we have found, interestingly, that female athletes have a lower rate of sudden cardiac death than young competitive male athletes. And they do also have lower rates of other types of arrhythmias like atrial fibrillation and potentially lower rates of what we think is exercise-induced coronary artery disease. Um, it's a really important because the data are really small. And so atrial fibrillation is a good story for this because male masters athletes have about a 5 to 10 times higher risk of developing atrial fibrillation than the general population, than a general healthy control. And for years and years and years, we thought that there was zero risk in female athletes. But then now, as studies are actually specifically looking at female athletes, there is a signal towards probably an increased risk in this cohort. And so I think we need to do two things. I think we need to be very careful on how we interpret the data and not say, hey, there's zero risk in female athletes when they've been restricted from studies. And I think that we need to all work together to improve enrollment and even making mandatory regulations for enrollment for these studies to be inclusive of female athletes, because there's lots of things we know that female athletes are not just little male athletes, and physiology is different, hormonal influences are different, life and societal influences are different. And so we need to be doing a lot better about inclusion of female athletes in sports cardiology research.
And just for people that are listening, if they don't know what a master's athlete is, would you mind just telling us what that means?
Yeah, so the broad definition, and this is going to age us, but most studies have a master's athlete for 35 years old. And so I'm getting there. I think Dr. Moulson may be there. But yeah, so that's generally the definition that's used.
Awesome. And Dr. Moulson, what are your thoughts about female athletes and things we should consider?
Yeah, so I crossed the master's athlete definition a while ago myself, and the athlete one is questionable as well. But yeah, very important topic. I think one of the things that I would echo everything that Brad mentioned. But there has been that concept or notion out there that female athletes may be immune to these cardiovascular associations with exercise, which I think is not the way to look at this. It's just we don't have the data there. The data has been sparse. And so there have been some suggestions that there may be some degree of lower risk. I think that concept of immunity and it doesn't need to be investigated further is incorrect. And I think as highlighted, we really do need to push to ensure that female athletes are included in future longitudinal studies. And also to better understand, I mean, we know from heart disease in general, there is some degree of protective effect. And then after menopause, there may be some catch-up effect in terms of increased cardiovascular risk. And I think you really need to hone in on that from an exercise standpoint, particularly with the shift of more and more masters athletes, particularly female athletes, kind of peri and post-menopause, continuing to do quite significant amounts of exercise and what effects those may have. And it'll also be studied out before we can actually really be able to address this in more appropriate detail.
I'll put in one more plug too. We need a lot more female sports cardiologists. Just like other fields in cardiology, it has been male predominated in the past, and we need more female sports cardiologists. Anyone who's interested in sports cardiology, reach out to us because we need more females involved in this. And we need more representation to move the field forward.
That was a great segue to our next question, which is you're both very early in your careers, although we haven't quite figured out how we define early versus mid-career. That was a whole nother episode. But you both built really impactful careers in a field that you've kind of had to just swim and create your own path here. But what advice would you give fellows besides reaching out to y'all, or even early career clinicians that are kind of in the general cardiology space, but are leaning more towards sports cardiology? Because as far as I can tell, it's never too late to kind of figure out what you want to do within the field. And so what advice would you give to people that are interested and want to learn more, and where should they start? Dr. Moulson?
Yeah, I will say, I guess my disclosure for this is I do work in Canada, so my advice will be from a little bit more of a Canadian context, but I did have the fortunate ability to train at the Mass General Hospital and getting a sense of that and how the US system works as well. But at this point, and I get lots of fellows asking me this exact question. So those that might be interested in other trainees, send emails, call us, just ask, how would I go about establishing this at my, planned institution? There isn't an accredited fellowship program for sports cardiology, although this may change in the future years. For fellows or trainees or even early career physicians interested in the topic, I would say if an opportunity exists for some form of non-accredited training from mentors in the fields, and there are more and more sports cardiology fellowships that are being established. So I know we've actually established one here at the University of British Columbia, accepting Canadian international graduates as well. And I'll let Brad kind of speak on the OHSU landscape as well. But those looking for maybe not that degree of formal clinical and research training, I think the sports cardiology world is small. I encourage them to contact people, attend the sports cardiology meetings if that's an area of interest for you. You can gain mentorship that way, and really just getting involved in that capacity, then to be able to understand and knowing who to call, phone a friend if you have questions around that as you start to get involved in the space. And then continuing your kind of clinical experience from there. Also free to reach out to either of us and consider joining initiatives such as the ASPC and the Sports Cardiology Working Group, which we are heading up right now.
Awesome. Dr. Petek?
Yeah, I think there are two big things. So the first thing is exposure. So just trying to get exposed to as much of it as you can. And so I think reaching out to lots of sports cardiologists in the field, I think trying to attend any sports cardiology related meetings that there are. And I think, it's exciting that ASBC is now having sports cardiology content at their meetings. So we were just meeting to talk about that. But trying to go to conferences because it's a very small world. So you're going to see all the people who do it around the world, these conferences. And then finally, there are some fellowship programs, as Dr. Moulson alluded to, that are coming about. And there's likely going to be a formal accreditation and certification process here that's coming. And so I would really, really kind of put a vote in for just really gaining as much exposure as possible. And that dovetails in a little bit into the second point, which is you really have to decide sports cardiology and what. So lots of people come out and they say, hey, Brad, I want to be a sports cardiologist, but you're not going to be able to just say, hey, I'm a sports cardiologist and have your 4 full days of clinic filled with this. And so I think sports cardiology is a very cool field because there are so many different opportunities and aspects because it's so broad. So, Dr. Moulson is an expert in prevention and in sports cardiology. So he sees general sports cardiology and sees all patients, and then he has an expertise in prevention. We have colleagues that have expertise in cardiomyopathy. So, hey, I'm a sports cardiologist, but I'm also an expert in hypertrophic cardiomyopathy, arrhythmogenic cardiomyopathy. And so I see those populations and patients. Now there's people who are doing sports EP and are really saying, hey, I want to take care of athletes with arrhythmias. So I recruited somebody on my faculty. He sees all of our athletes with arrhythmias and for better or for worse provides concierge EP care. So you'll get the EP study that instead of 6 months from now for your high profile athlete that needs it. And so I really think it's getting as much exposure as possible, trying to talk to as many people because we all have such varying different careers because the field is so broad. Dr. Moulson and I are very into prevention. There are some people that are, not into prevention at all, that are into cardiomyopathies or into other spaces. And so trying to figure out what your second thing is and also trying to gain exposure in the field as much as possible.
Awesome. Thank you guys. And I thought we'd end with a little bit of rapid fire. So feel free to just shout out your answer, I guess. But what is your favorite exercise to do?
Oh, to do it to this point from a myriad of prior sports related injuries, I would say my go tos in the summer are cycling and in the winter cross country skiing. Yeah.
Yeah, you can't see my body type on the screen, but I'm a runner and a cyclist that I like to do. But I think Dr. Moulson and I are both huge basketball fans to watch, and we're actually going to go to the World Cup together here in the summer. So we're excited to watch a game in Vancouver or a match in Vancouver, BC.
That's really awesome. What is one myth about exercise and heart disease you wish you could just bust for good?
I think athletes are not immune from heart disease. I think that is the biggest thing because so many people, so many patients say, "Hey, I went to a doctor and I said that I was running a 7-minute mile and now I'm running a 10-minute mile," and they said, "Oh, you're fine. You're exercising. You're good." And so I would say always listen to the athletes because they know best. They're attuned to their body, and exercise doesn't make you immune from cardiovascular disease.
Yeah. I was going to say the same thing, but I'll pick a different myth and for the interest of the podcast. But I agree. What that I would say I wish we could dispel for good is our job as physicians to make eligibility decisions over strict athletes from sports and exercise. Well, we may actually say to an athlete, the risks of continuing vigorous intensity or the sport of choice here may seem to outweigh the benefits from our standpoint. It really does take a much more nuanced and shared decision-making approach, understanding their wishes and desires as well, and moving from that concept of, we're here to determine eligibility or restriction to let's help determine whether or not it makes sense for you to continue on with your sport or exercise of choice.
Amazing. And what is something that you think general cardiologists, preventive cardiologists, any cardiologist could really learn from sports cardiologists? What is something we should, take away to our everyday clinic?
Yeah, so I think the preventative cardiologist could learn from a sports cardiologist really around how to take a good exercise history and understand that that's a great way to build rapport with this type of patient. So when you go into an interaction, if they're an athletic individual and they start talking about that, they really do want to convey that information to you because they think it is an important aspect of their cardiovascular risk discussion. And so being able to understand that and explain to the patients how that does factor in, but that you still need to consider guideline-based therapies, I think can be a valuable tool to kind of build that rapport and help patients to be able to understand their cardiovascular risk and make those appropriate decisions, particularly when it can be to initiate guideline-based preventative therapies.
I'll take the con and I'll say that I think sports cardiologists can also learn a lot from preventive cardiologists. And so one small thing is, athletes, masters athletes, predominantly male athletes, have been shown to have higher rates of coronary artery disease than healthy controls. And all of our studies that have proved this over years and years and years thus far, no one had looked at until months ago. No one had looked at what is the LP little a in all of these athletes. No one has looked at, hey, what about polygenic risk scores for coronary artery disease? No one's looked at inflammatory factors like high sensitivity CRP, which all could be confounders in all these analyses. And so I'm really excited that hopefully we build this bridge where, we can create the future of sports prevention specialists, and we can really ask these questions. How do you estimate risk in a very athletic patient? Are they at lower risk than other people? How do we design these studies to be able to really prove how the intersection of prevention and sports and exercise relate to each other? And so I think there's lots to learn from both directions, which is why we're very excited to have the American Society of Preventive Cardiology, be so involved and be so excited about building a sports section.
Well, this was an awesome episode. I feel like we just barely scraped the surface of all there is for sports cardiology, but what a great introduction for people who aren't familiar with the field. I'm sure that people listening are going to start emailing both of you and joining this section. And also lots of ideas for future episodes to chat more. Sounds like lots of questions that are getting answered, and then more questions that are going to be answered in the future. But thank you both so much for taking the time to come on the podcast today and chat with me.
Great. Thank you so much for having us.
Yeah, absolutely. Thanks so much. Really appreciate the time.
Thank you so much for listening. To learn more about the ASPC, please visit our website at aspconline.org.